All right, we're going to go ahead and start. Good evening, and thank you for joining us for this virtual community lecture focusing on knee and hip pain. My name is Ruth Tesfaye. I'm the Orthopedic Program Manager, and we are joined by our orthopedic specialist, Dr. Andrew Foster. Before we start, I wanted to let everybody know that this presentation is about an hour, and we'll have time for a question at the end. Please feel free to type your questions on the Q&A box. This webinar is not going to be open up for attendees to ask questions or to speak on the webinar, but please feel free to put your questions on the Q&A box. Before I introduce Dr. Wassef, I wanted to tell you a little bit about Providence Little Company Mary. We are part of Providence Health System. We are over 50 different hospitals in 3 different states. We are lucky to have specialties in orthopedic and spine here at our ministry here. We do about over 2,000 surgeries related to total joints a year on average. And then on a regional scale, we do about over 7,000 cases. So we're very fortunate to have the expertise, the knowledge, the skills, and the resources to be able to manage patient with knee and hip pain. And lastly, I just wanted to remind everybody the presentation that's going to be given today, it's for educational purposes. If you have any medical conditions or treatment options, please reach out to your healthcare providers. So without further ado, it's my pleasure to introduce Dr. Andrew Wassef. Dr. Wassef is board certified and fellowship trained orthopedic surgeon, specializing in minimally invasive and robotic assisted surgery. He has a special focus on joint replacement in the younger population. Dr. Wassef spent time teaching surgeons worldwide about how to adopt robotic assisted surgery in their practice and currently serve as a teaching consultant for Mako robotic assisted surgery. He has an interest in revision surgery, complex reconstruction, revision of failed total joint replacement. He's also our medical director for our complex revision cases here at Little Company of Mary. He received Vital Patient Choice Award and Compassionate Doctor recognition from 2016 to 2018. Dr. Wassef is married with 2 children and is active member of South Bay community. In his spare time, he enjoyed golfing and spending time with his family. So without further ado, Dr. Wassef.
Thank you, Ruth. I appreciate the introduction. Good evening, everyone. I appreciate you guys taking the time out to be with us this evening. I'm going to discuss a little bit about hip and knee pain. We're going to have time at the end, time at the end for questions and answers. So please feel free to type in your questions and we'll definitely get to those questions at the end. And hopefully you'll learn a little bit about the treatment options, about what we think about when people come to see us for hip and knee pain, and also what we provide at Providence Little Company of Mary in Torrance. All right. So, first of all, in terms of arthritis, it is really a very large population of patients that we see with this problem. Half of Americans are diagnosed with arthritis, really don't know what the options are. So really our job is to kind of help introduce you to the treatment options. It's really the #1 cause of disability in the United States and really worldwide. When you look at the amount of people that are afflicted with problems from arthritis, it's really quite staggering. It can limit everyday activities such as walking and dressing and bathing. And it also comes with a very large price tag, costing over $128 billion annually. Again, #1 cause of disability in the United States. Over 16 million adults in America say that arthritis limits their normal, usual activities of daily living in some way. And if you look at how many patients miss days of work due to arthritis, it's also a pretty staggering number. So it's really one of the number one causes of limitations in work life and home life as well.
Dr. Wassef,
Yes.
you're not sharing your slides right now. If you wanted to go ahead and do that.
Oh, I'm sorry. I thought
No problem.
Thank you. Okay, better? How's that?
Yes.
Okay.
Yes, much better.
Sorry about that. Thank you. Okay. So what we see is by the year 2030, an estimated 1/4 of the projected adult population 18 and older will actually have diagnosed arthritis. These numbers continue to rise. Every, decade, we see a significant increase in the amount of arthritis that we're seeing. And it's for various reasons that we'll discuss. So the value of a total joint replacement, when we really look at it over an individual's lifetime, can save quite a significant amount of money, really due to the amount of work missed due to arthritis. We all see, patients that after they get their hip or knee replaced are able to go back to a very active lifestyle and are able to go back to work in a meaningful way without having to miss work due to the pain from arthritis. The key to treating arthritis correctly is really, starts with the basics, diagnosis. So a proper diagnosis obviously will lead us to the proper treatment plan. First, we start with, a complete medical history, examination of the affected joint. Usually radiographs are taken to kind of examine the joint. And really the biggest key factor that we have to go off of is what you tell us as a patient. I think that's by far the most important thing, is just listening to what you tell us. Most patients really, are quite in tune with their bodies, and they come in and they pretty much tell us what's wrong. And it makes our life easy when people do that. So we do like for you guys to really understand what is hurting and when, and with what, what issues you have during the day in terms of your normal activities. So some of the factors that we really see increasing the risk of arthritis. There's systemic issues that can affect it, such as your age, gender. Definitely, we see a very large familial inheritance pattern with osteoarthritis, as well as different other causes of arthritis, such as rheumatoid arthritis. But we see a lot of patients that have, my brother and my sister and, my cousin, everyone had a knee replacement before the age of 60. We see that quite frequently. Other issues that can affect risk of arthritis is injury. We also, nowadays see a lot of people that have had, very active lifestyles at a younger age, sports injuries, and have had ACL tears and things of that nature. And so that can really predispose you to early arthritis. And then, of course, repetitive stress, people with jobs that cause, that are repetitive, high impact activity. Weight is a big thing that we really kind of focus on as well, due to the just natural increased stress that you put on the joint with being overweight, which obviously is a problem that we see in America. When you look at body mass index, which is a number that we use to evaluate basically where you are to the rest of the population when we look at your height versus your weight. So a BMI over 27, we start to see an increased progression of osteoarthritis of the knee. And a BMI over 30, which kind of starts to get into the obesity range, there's actually a 5 times higher increase chance of seeing radiographic changes of knee osteoarthritis. That's a pretty significant number when you think about it, because we really don't focus on weight as being an issue with arthritis. We talk about weight for diabetes and for all the other medical issues. However, it plays a very significant role when you talk about arthritis. And I'll tell you, I think, this slide I put in because I'm that guy. I think we're all guilty sometimes of our guilty pleasures here. So, or ordering fast food, but it's crazy not to have a diet soda. So I think it's important to always, keep in mind trying to remain active, trying to keep your weight at a reasonable level, because every pound that you have on your body is actually about 5 pounds of force through your lower extremity joints. So if you lose 10 pounds from your body, that's like taking 50 pounds of force off of every single step you take. And if you think about how much pressure that is off of your joints, that's a pretty significant number. Of course, being overweight accelerates the rate of cartilage destruction, and it also just makes it harder to get around and harder to exercise, before and after surgery. And when it does come time for surgery, being overweight also increases the risk of infection and other risks of catastrophic failure with a joint replacement. So that's why, you hear a lot of focus on weight loss and keeping the weight in a good zone, not just for surgery, but also to try to avoid surgery. So some of the conservative treatments that we often prescribe prior to really getting to the surgical treatment, we always want to try the easy stuff first. So, simple lifestyle changes, diet, exercise, medications, supplements, walking aids, all these things. Most importantly, really exercise. A lot of times we send patients to physical therapy to get their muscles stronger. As you increase your muscle strength around the joints, it drastically reduces the amount of force the joints see. So increasing your quadricep strength by 20% can decrease the risk of osteoarthritis by 30%. So something as simple as, getting a weight and putting it around your ankle and just, doing quad sets and working on your quadriceps to increase their strength can greatly reduce the need and the risk for future surgery. Water-based aerobic exercises can be great. We all saw with COVID and the pandemic, there was an unfortunate situation where so many people who were previously active were forced to remain in their home, and their activity level dropped, and they were no longer able to go to gyms and therapy and exercises. And so now, we saw so many people coming back with progressive severe arthritis and more progressive symptoms, because even if the arthritis wasn't much worse, their symptoms were much worse because they lost the strength and the muscle tone. So, anything you can do to stay active is very, very important. Braces can help sometimes. Canes as well can help. I always tell people, we see patients all the time coming in with a cane and they're using it on the same side as the affected joint. And it's actually meant to be used on the opposite side of the joint that's bad. And what that does is it greatly reduces the reactive forces that the joint sees. Walker, when things become a little bit more severe, and crutches temporarily also can provide some support and balance. Bracing, again, can be useful. It's a little bit cumbersome, obviously, to use a brace all the time. However, especially when you're trying to increase your activity level and exercise level, sometimes braces do help. Unloader braces, we call, are special braces that can reduce the stress of the forces going through one area of the knee. So it's great for people who have arthritis in only one area in the knee. And then, of course, injections. The most common type of injection that we do for arthritis is cortisone injections. For knee arthritis, there's also injections we call viscosupplement injections, which are, gel shots, which are more of a lubricating type of injection. But really all the injections are trying to reduce your symptoms. So the injections do not cure the arthritis. They have never been proven to change the progression of the disease. But what they can do is reduce your symptoms and allow you to stay mobile and stay active, and sometimes, give you several years before you really need any surgery. The hyaluronic acid viscosupplement injections, there's many companies. It's FDA approved only for knee arthritis. There are patients that when it works well can work for 6 to 8 months. So it tends to have a longer duration than cortisone injections when it does work. However, there are some people that respond much more to cortisone over the gel injections. So the only way to know is really to try. And so people that are trying to avoid surgery, these are good options to consider. Glucosamine and chondroitin. I have a lot of patients that ask me about this. The recommended dosage for knee and hip osteoarthritis is 1,500 milligrams of glucosamine and 800 milligrams of chondroitin. I always tell people, try it, give it a 2 to 3 month evaluation. And if you find that it is helping, then great, you can continue. If you find that there is no relief, then discontinue it. There's no real great scientific data that clearly shows benefit. There's research on both sides. Some show beneficial, some show no significant change. I think it's definitely worth trying the easy things again. And if it does help you, then great, try it and continue it if it does. When we talk about surgical treatment of arthritis, that's when we really talk about joint replacement. Total joint replacement is one of the most commonly performed and successful operations. Really, if you look at the survivorship and the patient satisfaction, it's just an excellent surgery that continues to improve, especially over the last 10 years. If you look at the volume estimates, we are just seeing an explosion of total joint replacements being performed, not only on younger patients, but older patients as well. We have a lot more active patients in their late 70s, 80s, and even in their 90s undergoing total joint replacements. We're also seeing a much higher rate of patients in their 50s undergoing total joint replacements. When you're thinking about considering joint replacement, I think you have to understand that there is an optimal window. I see people all the time that, just today I saw a young lady who is 87 and has, been recommended to have a hip replacement 10 years ago and was pretty resistant. And, the first thing she said today was, I wish I had it done 10 years ago. And there's definitely an optimal window before the deformity becomes worse and before your symptoms become so debilitating that you are no longer active and you really decline overall and you lose your muscle strength. It just becomes a harder recovery and a little bit less predictable. If you look at the studies that show surgeries performed at a later stage when the joint is very deteriorated, it results in worse post-operative functional status because your most predictive value of your post-operative functional status is going to be your preoperative functional status. So going into it healthier, obviously you can expect a quicker recovery and a more successful recovery overall. What we're seeing is definitely a paradigm shift in terms of the amount of activity that we allow after total joint replacement, and that's for several reasons. First of all, we definitely have more advanced operative techniques. I perform my joint replacements robotically assisted at Little Company of Mary in Torrance. We have 2 Mako robots, which allow us as surgeons to utilize this pretty revolutionary technology to give our patients the best possible outcomes. The materials are significantly improved over the last 15 years. And we also have younger and more demanding patient populations. So I have a lot of patients who are avid skiers and tennis players and pickleball players. And my job is to try to keep you active. So I want you being able to continue these activities following your joint replacement. If you look at the demographics, it's really shifting from previously where the grand majority of our patients were over 65. Now we're seeing again a huge shift to a much younger population for joint replacements. When we look at the hip joint, it's one of the largest weight-bearing joints, and it's a true ball and socket joint. The ball is the head of the femur, and on the socket side, we call the acetabulum. So the most common cause of hip pain is indeed arthritis, osteoarthritis being the number one reason. And it's, osteoarthritis is more commonly described as the wear and tear type of arthritis. It's by far the most common type of arthritis. There's also post-traumatic arthritis. People have had injuries and then have problems with the cartilage that result from a bad injury or a fracture. And then, of course, there's rheumatoid arthritis, which is a very different type of arthritis, which is actually caused from an immune system problem where it's actually your body almost attacking itself. And so it's an inflammatory type of arthritis. If you look at osteoarthritis, when looking at a hip x-ray, on the left there's a nice healthy hip x-ray. You have a socket, and you have the roof of the socket here, and then you have the ball, which is the femoral head, and you have space in between. If you look at a very arthritic hip, that space is completely gone, and we call that bone-on-bone arthritis. And then you start to see the big bone spurs, and this is typically a hip that is ready for a hip replacement. With inflammatory arthritis, sometimes you don't see the bone spurs, and what you see is a loss of the cartilage and the joint space. And this is actually a patient of mine who had a complete fusion of his left hip. So his arthritis, and this was at quite a young age. He actually went to high school with me, and during high school, he had to leave our school because he couldn't, go through such a big school with so many stairs because his hip had already started fusing. He went on, actually, I performed bilateral total hips on him. He had both of his hips done at a very young age, and fortunately did great and was able to remain active. But you can see, thinking of a hip that becomes completely fused, how debilitating that would be just for trying to get in and out of a car even. And then post-traumatic arthritis. This is a patient who actually had a fracture of his hip that was missed and untreated, and it actually the blood supply went on to die, and so he had a very severe deformity as an adult because he had an injury that was at a much younger age. And so this is a more complex situation that can occur. And at the end of the day, hip replacement can restore the function, restore the lengths of the lower extremities as well, and again, keep them active. So preparing for your doctor's visit, the orthopedic evaluation, again, is a thorough evaluation of really understanding what your issues are, right? So my job as an orthopedic surgeon is to help you reach your goal. Some people come in and their goal is to try to get a little pain relief and trying an injection and maybe doing some physical therapy. Other people come in and they've tried everything and they're desperate and they're ready to move on to a more serious step. So really, it's a decision that we make together. A physical exam, your medical history, x-rays again, and sometimes laboratory tests are needed to really come to a complete evaluation where we can actually diagnose you correctly and make sure that we have a good treatment plan for you. When we look at the recent technological advances with hip and knee replacement, really the biggest evolution has been in robotic assisted joint replacements. As Ruth alluded to, I spend quite a bit of time in my practice really kind of diving deep into the robotics and the history of robotics. I think it's pretty fascinating. I've been teaching robotics for quite a few years now, and it's just pretty amazing to watch the evolution that we've seen, where people are able to recover more quickly, people are able to feel more natural with their joint replacement, and it gives us a level of comfort as a surgeon, because I go into every surgery knowing I have an excellent surgical plan and I have a very strong tool to make sure that I nail the bullseye and that I'm able to reliably and reproducibly give you the best outcome possible. This isn't, experimental. This is something that has been around for quite some time, and it has really evolved into a very powerful tool. I personally have performed over 1,000 robotic assisted joint replacements. So it's not experimental. This is something that's really the future in terms of joint replacements. If you look at traditional hip replacements, what we do is in surgery, we make a cut and we remove the arthritic head and we bore into the thigh bone, the femur, and we kind of bore into it until we have the correct size. And then we put in a titanium stem. That stem has a roughened surface that mimics bone, and your body thinks it's bone and it actually grows into it. And that's how the stem becomes secured. Sometimes, rarely, we cement the stems into place, but usually it's a press fit, we call, where your body actually grows into it. Same thing on the socket side. We use a very expensive cheese grater and we remove the arthritic area, the bad cartilage and bone, and we prepare the socket, and then we put in a titanium socket again that the bone will grow into and become stabilized. And then in the middle, there's different bearing surfaces, we call. The majority of the time, it's a ceramic, high-grade ceramic head and a very high-grade plastic that goes in between. And that's what acts as your new hip. Also, for the knee replacement, very similar. It's not like we cut the knee out. We actually more of a resurfacing procedure. So we carve around to create a size for the bone to accept the components on both sides, on the thigh and on the shin bone. And then we put in the metal components, and in between is a very high-grade plastic. Now, when you look at traditional surgery versus robotic assisted surgery, the key difference really is that we previously were forced to use certain tools that were good tools. However, they were based on a bell curve. So everybody that came in generally to surgery, we had to prepare a knee replacement the same way. So there were certain angles we would cut. And if you were 6'2", or if you were 5'1", or if you had a prior deformity, all these things, we weren't able to really alter that. We had to kind of, use the tools that we had. And majority of patients, 85% of people did, quite well. However, there was definitely that bell curve of, the patients on both sides of the bell curve that didn't do very well. And part of that was due to the fact that we really couldn't appreciate their anatomy as well. With robotic assisted surgery, we're actually able to see that prior to surgery because we get a CT scan that goes through the knee as well as the hip and the ankle. We see the entire joint. Same for the hip. We go through the entire pelvis. So we're able to see both sides. We know your leg lengths. We know your deformity, and we know your size. And when we prepare the bone, we prepare it with a significant amount of precision, which reduces the actual soft tissue damage to the surrounding joints. So when we're looking at these CT scans, we have a very powerful preoperative plan. So when I go into surgery, I already know your size, I know your lengths, I know exactly where I'm going to put the socket, and I know where I'm going to put the stem. And the ability for me to do that reproducibly is significantly increased. So we don't have any surprises after surgery. And I think that's really the beauty of robotics. If you look at robotics in general, really, there's nothing, no industry where robotics has entered and not made it better and left, right? So robotics is definitely the future, and it's really going to be the standard of care quite soon. And if you look in our area, it really is becoming the standard of care very quickly. And it's definitely a great tool to utilize, especially if it's an option. So when we look at these 3D reconstructions of your pelvis, when we're doing these hip replacements, we're able to understand exactly how your hip and your pelvis will change going from a seated to a standing position. So we're actually able to see your hip replacement and what the x-ray will look like after surgery before we even do the surgery. So you can imagine the amount of comfort that we have going into these surgeries, and we're able to do these hip and knee replacements. Many of our patients leave the hospital the same day of surgery. I have a lot of patients, a little company that go home, 3 hours, 4 hours after their surgery, and we do that with confidence, and it really helps having this technology available. If you look at some of the research on robotic hip replacements, there's a very well-known study, guy, Rich Ilgen. He's a pretty famous surgeon, very well-trained. He did his residency at Harvard, fellowship at Mass General. First 100 cases in his clinical practice, he had a 5% dislocation rate with his total hip replacements. And he had 40% were within the range of where we generally like to put it. And then the blood loss was 533 mLs. If you look after 10 years of practicing, and he's a very busy surgeon with a very successful practice, 10 years of practice, his last 100 cases before he started robotic surgery, he had a 3% dislocation rate, and he increased the target to 48%. So after 10 years of practicing and thousands of total joints he performed, his dislocation rate only dropped 2%. If you look at his first 100 cases after starting Mako robotic assisted surgery, he had a 0% dislocation rate. So immediately using this technology, he was able to drop his dislocation rate to 0%. And he wasn't able to do that with 10 years of practicing. I think that really is a powerful statement, right? It really gives us a lot of insight into how much information we may have thought we had, but now with this type of technology, we're really able to reduce the mechanical failures of joint replacements. Again, with knee replacements, same thing. We have enhanced planning, the ability to visualize what your ligaments are giving us during surgery, and then the safety of the saw being kept in a very strict area to really reduce the amount of soft tissue, potential soft tissue damage to the result, to the surrounding soft tissues. So the real potential benefits we see: accurate placement, accurate alignment, reducing the risk of dislocations for total hip replacements, drastically reducing the risks of limb length discrepancy, and that means making one leg longer than the other with a hip replacement, and really just reducing the mechanical failures that we see. Now, when you look at how long will it last, that that's yet to be determined. It's very difficult to predict for an individual. There's a lot of factors, including age and weight and activity level and bone strength. So all these things kind of go into how long this will last. When you look at the 15-year data that we have, because these implants, the newer materials, which are much, much, much improved compared to the older materials, we've only really gotten 15-year data, and the 15-year data shows over 99% survivorship. So that means your risk of requiring a revision with these newer materials is really very low, without any extenuating circumstances. With putting these implants in robotically assisted, we also know that we're putting them in a better mechanical position. And what we can kind of extrapolate is that these implants will last longer when they're put in a better position. And we know that even now, a large part of my practice is revision surgery or redo surgery. And I redid a hip replacement that was done 40 years ago. 40 years ago, this hip last, and those materials compared to what we use now were quite poor. However, it lasted for 40 years because that surgeon hit the bullseye and he put that hip replacement in a perfect place. And even though that patient was quite active, it still lasted for 40 years. So, what our hope is that putting these implants in the perfect position and also having great implants now, our expectation is that these will last much longer. Recovery, also, quite different. When you look at hip replacement, the recovery tends to be easier than knee replacement. Knee replacement's a little bit more painful usually. We do a lot of special nerve blocks and injections to try to really reduce the initial pain. However, with physical therapy and all the work with the knee replacement that's required, there is definitely pain. And you have to go into a joint replacement understanding that it is a painful procedure for a period of time. However, if you work hard, you'll recover from it successfully and you'll go on to be very happy with it. Most people are in the hospital for, again, either leaving the same day or in the hospital for one night. Pretty rare that people need to be in there for more than one night. Most people have significant functional improvement, between the 2 to 6 week mark. By 3 months, most people are really doing very well. Hip replacements usually at 2 weeks come in walking, mostly without a cane and overall very happy already. This is a patient of mine that we did at Little Company, and he had, a total hip replacement, and this is him 2 weeks following his surgery.
Tell me, how far out of surgery are we? What'd you have done?
Let's see, I had a total hip replacement, and it was 2 weeks ago in 2 days.
And how old are you?
I'm 83.
83 years old.
Going on
Great shape.
84 in July.
All right. So you had a Mako robotic assisted direct superior hip replacement. Go ahead. Show us what you got.
Bionic man.
Bionic man. Show us how you're walking.
So you can see after 2 weeks, he's walking without a
No
limp.
pain.
No cane, no walker,
No pain with walking.
no pain. Just,
No
like
soreness.
1/2 of one.
Excellent.
And hopefully you heard the audio on that,
Okay.
but basically what he was saying is 2 weeks after surgery, he's, walking with very little pain. And you can see he's 83 years old, and at 83, he's in great shape. So keeping yourself in good shape, keeping your muscles strong, staying active is really the key takeaway I want everyone to have. Is it's very important to really try to keep active and remain strong. When you look at the potential causes of failure of total joint replacement, the articular bearing wearing out, so the plastic in between can wear out. That usually in normal circumstances happens over many, many years. Mechanical loosening, so sometimes the cement bond can loosen, sometimes the bony ingrowth surface can loosen. All these are rare, however, these are really the main potential pitfalls. And then dislocation of hip replacements and instability of a knee replacement. Infection, definitely something we really worry about. And again, diabetes and obesity are really the two main things that we really worry about. Those create a much significant increased risk of infection. Metal hypersensitivity, people worry about quite often. It's a very rare issue to see. However, that also can be a potential problem. When you look at revisions, they're very highly specialized procedures. They're performed, most commonly by fellowship trained joint replacement specialists. And also really having a facility that specializes in treating these complex cases is very important. At Providence, a little company in Torrance, that really invested in creating a specialized program for treatment of these difficult cases. And that's, I think, a very, very important factor when you think about undergoing surgery for failed total joint replacement. Hopefully this was beneficial for you. And again, thank you guys, and thank you, Providence Little Company, for putting this on, and happy to take questions.
Thank you, Dr. Wassef. That was very informative and interesting presentation. And the one thing that I will echo is I can tell you that working with total joint patients after surgery, I hear this all the time. They said they wish they've done it earlier. So I just wanted to echo that to you. So thank you. Before we get to our Q&A, if you were asking a question, if you guys could answer the poll on your screen that you see there and give us your feedback. We really appreciate that. So let's go to your Q&A here. So one of the questions, Dr. Wassef, is they want to know how likely you're going to need a revision. I think you kind of touched on it a little bit earlier. And somebody's asking, they've had their knee done 16 years ago, and what is the likelihood they're going to be needing another one?
That's a good question. So really, again, that's highly dependent on your activity level. A lot of factors go into that. I always tell people, if you've had a total joint replacement over 10 years ago, you should really come in, see your orthopedic surgeon. If you don't have one, see a new one. You should have x-rays. And a lot of the problems that we see from the components wearing out, we're actually able to visualize that on x-rays prior to you feeling that as a patient. So it's worth getting an x-ray, getting a baseline. You don't have to get x-rays every 6 months, not that often, but getting an x-ray every couple of years after the 10-year mark is beneficial, just to kind of keep an eye on things.
Okay. All right, thank you. And then another question is somebody who had partial surgery 16 years ago, and I'm assuming it's still, pretty good. So is that considered a good outcome for partial or for uni?
That's an excellent outcome. And partial knee replacements got a little bit of a bad rap, when you look at the historical data, because it's a difficult procedure. It's actually a more difficult mechanical procedure than a total knee replacement. It's a less forgiving procedure. So when you look at the outcomes of partial knee replacement and you look at robotic assisted versus non-robotic assisted, there's actually a very drastic difference. And that's not even just in our own data here in the US. That's actually been seen in the multiple databases outside of the US. So the Australian database, which they have a very robust database that shows every single patient that underwent a partial knee robotically versus non, and even the data from Great Britain. So we definitely see more partial knees being done with surgeons that have adopted robotic assisted surgery, because again, it's just a home run surgery when it's done in the right person. And again, it has to be done in the right patient for the right reason, but when it is, it's a really fantastic procedure.
All right, thank you. Another question is, can we do MRI after metal implant?
So when you talk about a joint replacement type of metal, yes, you are able to. There's actually even special MRIs that are performed on the same joint. So people that have had a total knee that may have a tear in the tendon or something, sometimes we get an MRI, and there's a special type of MRI that you're able to get. However, regardless, anytime you have a total joint replacement, it is safe to obtain an MRI.
Okay. All right, thank you. And the other question is, how young would you do a total knee surgery?
So that's a good question. I'll say I'm the one of the there's not a lot of fellowship trained joint specialists in the area, and so I tend to see a lot of the more complex cases in the younger patients. Total hip replacements, my youngest total hip replacement was 15 years old, very extreme circumstance. I have done quite a few hip replacements in patients in their teens and their 20s. Again, these are all pretty extreme circumstances, not just wear and tear arthritis. Knee replacements, I would say we're a little bit less comfortable as an orthopedic community to do on younger patients, because we have not actually yet seen how long what the expected lasting of the materials will be. My patients, the youngest knee replacement that I've done is a 38-year-old. And would I be willing to do it in a younger patient? Yes, I have a patient actually that I'm in the process of planning surgery, who is she's 19, again, a very extreme circumstance. So rare that we do knee replacements in very young populations. However, in patients in their 40s and 50s, we're definitely doing a much higher rate of those, and we're very comfortable doing it at that age now.
Okay. The next question says, please comment on emerging treatments, stem cell injection, platelet-rich plasma injection. What's promising?
Good question. I have a lot of patients that ask me about that, and I've had many patients that go and get stem cell injections. And the data, hasn't really supported stem cell injections for treatment of arthritis. Actually, if you look at the Academy of Orthopedics, they're pretty strongly against it because unfortunately, there's a large, I would say, financial burden to the patients, and also a large upside to some of the people that are doing these injections. And so you do have to be careful who's giving you the injection and what's being given. If you really look at the stem cells in America, most of them are cryopreserved, which means they're pretty much dead, cells. They're really not live pluripotent stem cells. So we don't have, true good stem cell injections that we've actually had good data on. If you look at PRP, the platelet-rich plasma, I have had patients who have had good results with that. I think there is some credence to it. However, there's never been an injection that's actually proven to reduce the progression of arthritis. If someone figured out how to cure arthritis, this would be big news. They'd be a Nobel Peace Prize winner, right? This is a multi-billion-dollar, trillion-dollar industry, right? So this wouldn't be something that would be found in, someone's back office getting a $4,000 stem cell injection. This would be public knowledge. So I think you have to, proceed with caution in terms of looking at some of these injections. I don't think it's a bad idea to try PRP. I think PRP works excellent for certain inflammatory issues like tendonitis and can help with arthritis as well. I don't think it's a bad option. The stem cell injections, I think I'd be a little bit more cautious about.
Okay. Attendants also asking, why is my knee osteoarthritis feel more like a stiffness around both upper legs than sharper pain?
So good question. Everyone feels pain differently. I have people that come in with extremely arthritic knees and hips, and they say, oh, I feel stiff. I feel heavy. I feel stiff. I have people that come in with, much more moderate arthritis, and they have severe sharp pain. So I think, we all know there's a different pain tolerance in the population. Some people tolerate pain very well, and other people do not tolerate the pain from arthritis. And arthritis is also very cyclical. Sometimes you have a lot of acute inflammation, which would create a lot of fluid and a lot of swelling, and that tends to be much more painful and sharper pain.
Okay, thank you. Another question says, can knee and hip pain be related?
Knee and hip pain can be related, and more often back and hip pain is very often related. And there's something we call the hip spine syndrome, where I see a lot of people who come in or referred to me for hip pain, and it's really not their hip, it's their back. And so I have a very close relationship, with our spine specialist, and Dr. Ajiboye, we send people back and forth to each other quite often, because he sees people all the time, and he's like, oh, it's not your back, it's your hip. So that tends to be more closely intertwined. However, a lot of people with hip arthritis have pain radiating to the knee, and they feel the pain in the knee. A lot of patients undergo hip replacement, and their knee pain completely disappears. So there is a large population that has referred pain to the knee that is actually coming from the hip.
Okay, thank you. And then there's a question also, can I start directly with Dr. Wassef, or do I need to start with my PCP? And I guess the PCP is part of the Providence also.
That's dependent on a lot of factors. Really it depended on mostly insurance, right? If you're a self-referral type of insurance like Medicare or PPO, then generally you can come see me directly. If it's HMO or more managed care, then generally you have to get a referral. So it kind of depends more so on the type of insurance that you have, whether or not you can come directly or need a referral.
Okay, thank you. And then says here, how soon after knee replacement would I be able to do stairs?
So again, that's greatly dependent on your preoperative muscle strength and tone. I have many patients that go home the day of or the next day of surgery, and they have a flight of stairs that they need to go up and down. It's a little bit difficult after knee replacement to do a whole flight of stairs. The day of, most people need a couple of days to kind of work up to get there. However, I always recommend if it's an option to stay downstairs for a day or two, just so you don't have to worry about going upstairs, do that as you start to practice the stairs. However, it's definitely an option for people after knee replacement, and a lot of patients are able to do it after a couple of days. But I would say realistically, comfortably, it's probably closer to about a week.
Okay. And then there's attendee that apparently had a partial knee replacement in 2010, and then had a revision in 2011. Then it failed, and he ended up having another one in 2016. So I guess what will be the next option? And the attendee feels like it's failing again. So what will be the best approach to deal with this?
Well, I think it's having a thorough, those are complex situations where you really have to have a very, very thorough evaluation. And that's by far the most important thing is A, is it failing? B, why is it failing? And understanding the underlying reasons. So I think getting in to see a joint specialist to really, be able to evaluate exactly what's going on and why is the most important thing. And are there patients who have had multiple revision surgeries? I've had patients who have had 10, 12 surgeries before getting to me. And so, it's not like there's a finite number of surgeries. However, of course, we don't do these surgeries without really being necessary, because every revision surgery is a more complicated one.
This next question, actually, I would love to hear what your comment is. Says, do I need to do my hip first or my knee? Because this attendee says they needs both.
So, usually when people need a hip and a knee replacement, the deciding factor is a couple of things. A, deformity. So if they have a knee that is very deformed, then we tend to tackle the knee first, because we don't want that deformity to progress. Same thing with the hip. If you look at people that have hip and knee arthritis and it's equal, then generally we usually start at the hip, because a lot of times doing the hip replacement, people actually get some relief from the knee. And it's actually a little bit more difficult to get around a very arthritic hip. So getting in and out of bed can be extremely difficult with an arthritic hip. Sitting down on the toilet. With an arthritic knee, people are able to kind of walk with a stiff leg, and they're able to compensate a little bit better. So if all things are equal in terms of the amount of arthritis and deformity, most times I usually recommend start with the hip. It's a quicker, easier recovery, and it's kind of a slam dunk in terms of getting back to normal activity. And then you do the knee. Because you're going to need to do a lot more therapy with the knee. So you really want a hip that's not going to hold you back. So usually I start with the hip first.
Okay. And the next question says, can meniscus tear surgery be done along with the knee surgery?
So meniscus tears are, tears in the supporting cartilage of the knee that when torn in the setting of arthritis, it's not generally treated arthroscopically. So when you have a tear in the meniscus and you already have arthritis, then that's just the progression of arthritis. Very few patients who have bone-on-bone arthritis don't have meniscus tears. Almost all of them have meniscus tears. That's just the normal, natural progression of arthritis. So the meniscus during the knee replacement is actually completely removed, because we don't want that to be a problem. So we actually excise the meniscus on both sides when we do a knee replacement, so that way it does not give any potential pain after surgery.
Okay, thank you. I think we got most through all the questions here. There's one question about what criteria does Medicare require to pay for a total joint? And I think I did answer to the attendee that it has to prove that there's arthritis and they've tried less invasive procedure before the total joint gets approved, right, Dr. Wassef?
Yeah, so usually, and not just for Medicare, right? But that's just, for us as physicians and anyone in the medical field, we don't want to do a surgery that's not necessary. We don't want to put you through, even if it's a super successful surgery and outcomes are great, there's always a risk with anything. So we don't want to, put you through a surgery that's not necessary. So, trying again, the easy stuff, physical therapy, injections, is usually the pathway. Now, there are patients that when we see them, they have bone-on-bone arthritis, deformity. We don't waste time and say you have to do therapy, you have to do injections. No, those are patients that can bypass that because it's not absolutely necessary when you have such progressive disease. So there are patients that we say, it's not necessary to do an injection, because if you have severe bone-on-bone arthritis or obliteration of the hip joint, an injection is definitely not going to help. However, for more normal circumstances, we don't like doing joint replacements on people with mild arthritis. If you look at the outcomes of total joint replacements, people that go in with mild arthritis and have a joint replacement have a less chance of a successful, happy outcome at the end of the day than people that go in with more moderate to severe arthritis. So we do want to see people that have, really tried to deal with their arthritis and have gotten to the point that they've failed normal measures in terms of treatment.
Okay, and then we just have one more question because we're reaching out time here. Can you get a replacement, knee replacement if you have osteoporosis?
Yes, good question. We have a lot of people in the patient population who undergo hip and knee replacements that do have osteoporosis. And if you look at the treatment for people that come in with hip fractures, those are almost always osteoporotic patients. And the way we treat it is with hip replacement. So there are certain precautions we take. There are, certain things that we do to try to make sure that with osteoporosis, we have a successful outcome. There are patients that have severe osteoporosis that I do recommend trying to increase their bone density by medical treatment prior to joint replacement. However, at the end of the day, there are always options to work around the osteoporosis. But it is a good question. It does, it can pose some significant challenges with hip and knee replacement.
Okay, well, I think we went through all the questions, which is great. So thank you, all of you, for taking the time to really listen and ask questions. And I particularly want to thank Dr. Wassef for taking time from his busy schedule to do this lecture for us. We will be providing you a video to you guys for you to keep. We're also posting this on our Facebook for everyone to be able to view and share. You can find us at Little Company of Mary South Bay on the Facebook for any additional information or scheduled a physician appointment. Please call our patient engagement center at 844-925-0942. So thank you again and have a great rest of the evening.
Thank you, Ruth.
All right, thank you.
Take care.